My name is Dr. Alistair Finch, and for 2 decades, I was the chief of neurosurgery at St. Jude's University Hospital in Denver. I say was because I tendered my resignation 6 weeks ago. In my career, I've navigated the delicate geography of the human brain over 2,500 times, excised tumors the size of fists, and witnessed the astonishing resilience of the mind to heal itself. But this story isn't about any of those triumphs. It's about the one patient who forced me to confront the chilling possibility that our understanding of consciousness and its endpoint is fundamentally flawed. St. Jude's is a major academic medical center, the place where the most complex neurological cases in the Mountain West end up. I'd seen it all: devastating strokes, intricate vascular malformations, and traumatic brain injuries so severe that recovery seemed like a fantasy. We were known for pulling people back from the brink. The case that unraveled my certainty started on a crisp October night in 2022. I was reviewing post-op scans when my phone rang at 10:15 p.m. It was Dr. Anya Sharma from the emergency department. "Alistair, we have a massive subarachnoid hemorrhage coming in. 42-year-old male, collapsed at home. GCS of 3. We're taking him straight to neuro ICU. I need you there now." I met the gurney as it burst through the ICU doors. My team was already in motion. My lead neurocritical care nurse, Helen Carter, had been my right hand for 15 years. Our anesthesiologist, Dr. Ben Carter, was the calmest person I knew in a crisis. We were a well-oiled machine, ready for the worst. The patient was Samuel Miller, a 42-year-old librarian from Boulder. His partner had found him on the floor of his study, surrounded by books, making a terrible gasping sound. He was unresponsive when the paramedics arrived. His journey to us was a chaotic battle to keep him oxygenated, but his prognosis was grim. His blood pressure was sky-high, his pupils were blown, and he had no motor response. We immediately intubated and began emergency measures to reduce the intracranial pressure. "How long was he down before the 911 call?" I asked the paramedic while we hooked him up to the monitors. "Partner thinks maybe 10 minutes max. We've been bagging him for 20, but he's shown no response to anything." Not good. 10 minutes of hypoxia can cause catastrophic brain damage, but you never call it until you've exhausted every option. The brain is a universe of its own, full of surprises. For the next 5 hours, we fought a losing war. We'd get a flicker of improvement in his cerebral perfusion pressure, only for it to plummet again. We administered every drug in the neurocritical care arsenal, drilled a burr hole to place an external ventricular drain, and flooded his system with hypertonic saline. Nothing worked for more than a few minutes. Helen kept a close eye on the monitors. "Alistair, his EEG is flat, no brainstem reflexes, no response to deep pain stimulus on any limb." I performed the checks myself. No corneal reflex, no gag reflex. I performed the cold caloric test. His eyes remained fixed, staring into nothing. The transcranial Doppler showed no blood flow to the brain. At 3:22 a.m., having thrown the entirety of modern neuroscience at him, I had to do the one thing a doctor never wants to do. Time of death, 3:22 a.m. We had followed every protocol for determining brain death. Samuel Miller had no discernible brain function, no respiratory drive off the ventilator, and no cerebral circulation. His core body temperature had begun to fall despite our warming blankets. By every medical and legal definition, Samuel Miller was dead. I went to the family consultation room. His partner, a man named David, was there with Samuel's sister. This is the part of the job that never gets easier. I sat with them and explained, in the quiet, sterile language of medicine, that the hemorrhage was too severe. "I'm so sorry," I began, the words feeling hollow and inadequate. "We did everything we could. The damage to his brain was irreversible. Samuel is gone." David let out a sound of pure anguish that seemed to be torn from his soul. I gave them time, then gently explained that they could sit with him and that we would need to contact the organ donation network as per his driver's license. What transpired next violates every law of biology I have ever studied. At around 4:45 a.m., I was at my desk, filling out the mountain of paperwork that follows a patient's death, when Helen burst in, her face ashen. "Dr. Finch, you need to come to ICU Bay 4. Right now, something's happening." "What do you mean, something's happening?" "The ventilator alarm. It's showing patient-triggered breaths, strong ones." I stared at her, my mind refusing to compute. "Helen, we confirmed brain death over an hour ago. Did someone bump the machine?" "That's just it. Nobody was in the room. We were waiting for the family to come back. The machine just started alarming on its own." I sprinted to the ICU, certain it was an equipment failure, but the scene in Bay 4 stopped me cold. It was a sight that tore a hole in my reality. Samuel Miller was lying on the bed, his eyes open. He wasn't just breathing over the ventilator, he was looking around the room with an expression of mild curiosity, as if waking from a nap. I stood there, paralyzed, my own heart hammering against my ribs. This wasn't possible. I had personally confirmed the absence of every single brainstem reflex. I had seen the flat EEG, the silent Doppler. He was brain dead. Dr. Carter, who had also been summoned, was already at the bedside, his hands shaking as he checked Samuel's vitals. The blood pressure 120/75, heart rate 80, oxygen saturation 99% on minimal support. Pupils are equal and reactive. What the hell is going on? How long was I asleep? Samuel asked, his voice raspy from the breathing tube but his words perfectly clear. He raised a hand and pointed to the tube, and we quickly moved to extubate him. I approached the bed, my mind reeling. Samuel, can you tell me what you remember? He blinked, his gaze sharp and intelligent. I remember being in my study. I had this splitting headache like nothing I've ever felt. I remember calling for David, then nothing, until a moment ago. I conducted a full neurological exam. His cranial nerves were all intact. His memory of the events leading up to his collapse was perfect. His speech was fluent, his logic sound. There was absolutely no clinical evidence that his brain had been deprived of oxygen, let alone declared dead. Samuel, I have to be direct with you. At 3:22 this morning, we pronounced you dead. That was more than an hour ago. Your brain had ceased to function. There was no blood flow, no electrical activity. He looked at me with his calm brown eyes, taking in this impossible information. Dead? You mean actually dead? By every established medical criterion, yes, you were. Well, I'm here now, he stated, with undeniable logic, and I feel clear. The headache is gone. I feel rested. I couldn't argue, but I couldn't explain it either. I immediately ordered a new round of every conceivable test, STAT CT scan, MRI with angiography, a new EEG, a full metabolic panel. If Samuel had somehow survived brain death, I had to know how. Dr. Sharma arrived, her face a mask of disbelief as she reviewed the timeline. This is a joke, right? I was here. I saw the initial scan. His brain was full of blood. I saw the flatline EEG myself. I know, I said, my voice strained. But he's in there asking when he can have some water. The test results only deepened the mystery. They were all normal. In fact, they were better than normal. The massive hemorrhage that had filled his brain just hours ago vanished. The follow-up MRA showed a pristine vascular structure. The EEG showed healthy synchronous brain waves. There was no medical explanation for his survival, let alone his perfect recovery. The story of Samuel Miller ignited a firestorm in the hospital. Colleagues from every department, cardiology, ethics, risk management, were suddenly at my door. How could a man come back from brain death? What did we miss? Dr. Evelyn Reed, our chief of neurology, spent hours with Samuel. Lester, she told me in confidence later, I've been doing this for 35 years. I've never seen anything like it. After that level of intracranial pressure and hypoxia, he should be in a vegetative state at best. He's showing zero neurological deficits. It's as if it never happened. The hospital's ethics board convened an emergency session. The state medical board was notified. Everyone assumed a catastrophic error on our part, but I knew we had made no error. I had performed the exam. I had seen the data. Samuel Miller was dead, and then he was alive. As I started digging into the medical literature, I found scattered obscure references to something called Lazarus syndrome or autoresuscitation. But those were almost exclusively cardiac cases, where circulation spontaneously returned after CPR was stopped. This was different. This was the brain. This was the brain. The most famous case I could find was a woman in South America who revived in her coffin. But even these stories were rare and poorly documented. What struck me about the few credible accounts was the same pattern. The patients didn't just come back, they came back whole. They returned without the devastating impairments that should have been inevitable. Samuel stayed with us for 3 days for observation. I spent hours talking with him, trying to piece together what had happened in that lost time. Do you remember anything at all from when you were gone? I asked him one afternoon. He was quiet for a long time, looking out at the Rocky Mountains. You're going to think I'm insane. Samuel, at this point, I'm ready to believe anything. It wasn't darkness. It was a place made of quiet. I was in a vast, endless library, but the books weren't made of paper. They were made of light. And I knew somehow that every book was a life, a story. This was far more specific than the typical near-death accounts. I felt this incredible sense of peace, he continued, like I was home. I saw a door at the far end of the room. and the light coming from it was warm and inviting. I knew if I went through it, the story would be over. But then I heard something. What did you hear? A piano, a simple little melody. It was the piece my daughter is learning for her first recital, and I thought, I can't miss that. So I turned away from the door and walked back. The next thing I knew, I was here. I checked the nursing notes. David had been in the room with Samuel's body at approximately 4:40 a.m. He had been playing a recording of his daughter's piano practice on his phone. The ventilator first alarmed at 4:45 a.m. Samuel's recovery was flawless. Within 48 hours, he was back to his baseline. His neurological exams were perfect. It was as if his brain had been rebooted. I've never felt so sharp, he told me as he was being discharged. It's like my mind was wiped clean of all the clutter. This case left me with profound, terrifying questions. If Samuel could be brain dead for over an hour and return perfectly intact, what was our definition of death? A legal and medical fiction? How many others had we unplugged who might have been on the verge of a similar return? The hospital's lawyers were in a panic. Had we declared him dead prematurely? But the protocols were the protocols. He met every single criterion. His return didn't invalidate the diagnosis. It invalidated our understanding of the diagnosis itself. Samuel went home. I saw him in my clinic at regular intervals. His recovery held. He was back at the library, living his life as if nothing had happened. But I was changed forever. I started to hesitate. With every patient teetering on the edge of brain death, I'd wait. I'd run another set of tests, and another. My colleagues grew concerned. Alistair, you can't let one bizarre case dictate your practice, Dr. Sharma told me after I'd kept a patient on full support for 48 hours past what any other neurosurgeon would have. How do I know? I asked her, the question raw. How do I know they're truly gone and not just, you trust your training, you trust the science, that's all we have. But Samuel's case had demolished my faith in that science. If the rules could be so spectacularly broken once, they weren't rules at all. 6 months later, another case. Eleanor Vance, an 82-year-old woman with a terminal glioblastoma. She was in hospice care at home when her nurse found her without a pulse or respiration. The hospice doctor made the declaration of death. The body was transported to the hospital morgue, awaiting the funeral home. I only got involved because the morgue attendant called the ER in a state of shock. At 2 a.m., nearly 4 hours after she was declared dead, Eleanor Vance had sat up on the gurney and asked for a blanket. She was brought to my service. Her vitals were stable. Her mind, which had been clouded by the tumor for months, was lucid. She was witty and sharp. But the most impossible part came from her new brain scan. The massive, inoperable tumor that had riddled her temporal lobe was gone. There was only healthy brain tissue. "How are you feeling, Mrs. Vance?" I asked, my own voice unsteady. "Quite well, doctor. A bit chilly. Is it true what that young man said, that I was dead?" "According to the official report, yes, you were." She gave a wry smile. "Well, reports can be mistaken." Eleanor's case solidified my fear that this wasn't a one-off anomaly. This was a pattern. 2 patients, declared dead by all standards, who not only revived but returned in a state of impossible health. Both reported a profound conscious experience while they were dead. I started compiling a private file, documenting every detail. I found more cases in obscure journals than I expected. The duration of death varied from minutes to, in one case, nearly a full day. And in every instance where a follow-up was possible, the patient was neurologically perfect. Most unnerving of all, the reported incidents seemed to be slowly increasing. My obsession with the topic began to isolate me. Families of patients who didn't recover started asking why their loved ones didn't get a miracle. Colleagues began to see me as a liability. "Alistair, you're one of the finest surgeons I've ever known," Dr. Hendricks, the hospital's chief medical officer, told me. "But this has to stop. You're ordering tests that aren't indicated. You're creating false hope." "What if it's real hope?" I countered. "What if we're just too arrogant to see it? You can't practice medicine based on miracles, you know that." But I couldn't forget. How many people had we failed because we followed the book instead of waiting for the impossible? My relationships at work frayed. My surgical caseload was subtly lightened. I was becoming an outcast in the department I had built. The final case, the one that made me walk away, was a 22-year-old woman named Maria Sanchez. She was in a horrific car accident. Despite our best efforts, her brain swelled uncontrollably. After 36 hours, she met all criteria for brain death. Her devastated family agreed to organ donation. I wasn't her primary surgeon, but I was asked to perform the official declaration. As the organ procurement team was prepping in the adjacent OR, something made me run one last EEG. Dr. Carter called me from the control room. "Alistair, you need to see this. We have activity. Spikes in the temporal lobe." I found Maria lying in the ICU bed. A single tear was rolling down her cheek. Her recovery was as complete as Samuel's and Eleanor's. But for me, it was the end. The hospital was thrown into chaos. The organ team had been minutes from starting the procurement. The legal exposure was immense. I knew then I could never sign another death certificate. How could I make that ultimate declaration when the very definition of the word had crumbled before my eyes? I submitted my resignation the next week. "Alistair, don't do this," Dr. Hendricks pleaded. "Take a leave of absence. Process what you've seen." "Patricia, I've seen 3 people come back from being brain dead. Not near death, dead, and they came back perfect. That's not supposed to happen. They are outliers, statistical impossibilities." "Not to them. They're not. There's a piece of this puzzle we're missing. A huge piece. And I can't keep cutting into people's brains while pretending I know where the person inside it actually begins and ends." I left Denver and now run a small clinic in a quiet mountain town. I treat ski injuries and altitude sickness. I never have to make a decision about life and death, but the 3 cases follow me: Samuel Miller, Eleanor Vance, and Maria Sanchez, all pronounced dead by accepted medical standards. All returned to life, whole and unexplained. What haunts me are all the patients we didn't wait for. How many others were in that library of light, listening for a reason to come back? The medical community wants to file these events under unexplained phenomena and move on, but I can't. I looked at the monitor and saw a flat line. I signed the form, and then he came back. I've continued my research. Some theorize it's a delayed reboot of the brainstem, a cascade of cellular processes we don't understand. Others suggest our methods for declaring death are too crude, but I did the exams. I know what brain death looks like. These patients were gone. The most radical possibility is that consciousness is not purely a product of the brain. If Samuel could be in a library of light while his brain was silent, if Eleanor could feel peace while her body was in a morgue, what does that say about who we are? Samuel Miller is still a librarian and attends his daughter's piano recitals. Eleanor Vance lived for another 5 vibrant, tumor-free years before passing away in her sleep. Maria Sanchez finished college and is now a social worker. They all ask me the same thing: why us? Why did we get to come back? I have no answer. All I know is that what I witnessed shattered my understanding of my craft and my place in it. The mind that woke after midnight will haunt me forever, not because it was frightening, but because it showed me the vast, humbling depth of our own ignorance. Sometimes, in the quiet of the mountains, I wonder how many other stories aren't over, how many people are just waiting for us to listen. But that is a weight I can no longer carry into an operating room. Some questions are too big for one man's hands, and some mysteries run deeper than any scalpel can cut. The brain may stop, but the story doesn't always end.